We're moving on to our next session, and for that I would like to invite the chairpersons for our next session. Dr. Yogesh Kulkarni. Dr. Somsekhar. Please join us on the stage for this. Thank you, Dr. Somsekhar, for joining us. Let's take over.
Thank you very much. It's a pleasure and honor actually to have a president oration in such a great congress. Also to have a honor of introducing my great friend who started journey of robotics with us. You know, the initial robotic was in Bulakad on an unlaid village road with 10 people criticizing, another 20 waiting something goes wrong. And then you go back home at a part of your career where your family would ask, why you want to do at this part of career, having been successful doing everything in open lab. And that was the passion with which Ruma started the journey with all of us. So it's my honor and pleasure actually to introduce Dr. Ruma Sinha. She's a gynecologist and minimal access robotic surgeon in the Apollo Health City, Jubilee Hills, Hyderabad. She has like enormous amount of awards. Just to name few, she received FIGO Fellowship in year 2000, and she's also AOFOG Young Gynecologist Award in 2002, Kamini Rao Yuva Oration 2004, Vasant Saheb Scholarship in Eurogynec in 2005 from Melbourne, and she also received the Legend in Gynecology in 2011 from Times Healthcare Achievers. She also received a Distinguished Clinical and Clinical Tutor Award both from Apollo 2 times, 2018 to 21, and she also received an RE of the Decade and Best Robotic Surgeon in 2018. She holds an MD with multiple gold medals. That shows in the magic she commits in the robotic. And it's my honor and pleasure to invite and hand over the stage to Ruma to give the presidential oration today.
Thank you, Dr. Somsekhar, and thank you for joining us for this meeting of RoboGyne India. We missed you last year, but thank you for making this journey for us today. So, this presidential address that I wanted to give probably will cross path a little bit what just Arnie spoke about. But I'm just going to take you through a little bit of history and what we have been doing. So the current technology that we are hearing, and maybe a little bit talking about what's going to come, do you think it's an evolution or is it a complete disruption of what we have been doing as surgeons? Let's begin with a history of our own country. Indus Valley Civilization, 2500 to 1900 BC. We get the first description of doing surgery in that period. But that we just got lost somewhere. Although we have documented books by the great Indian surgeon called Shushruta, who practiced in the banks of river Ganges in 6th century BC. In fact, I have studied and done all my medical education on the same banks in a very big university, and that's Banaras Hindu University. Take very big pride in it. But this father of surgery has his own rhinoplasty being quoted in the Converse, which is a plastic surgery textbook. You can find this particular picture that I picked up is actually presence of this idol in the Royal Austrian College of Surgeons in Melbourne, considering that as a father. But we also have other people who have been in this journey. It's interesting to note that in Shushruth's contribution to endoscope is not very well known. It wasn't the kind of endoscope we talk about today, but it was categorized as a tubular instrument, the Nadi Yantra that he used to call, which he would put inside all the orifices to examine. So it was the first so-called evolution in terms of the so-called telescopes that we know today as endoscopes. But I think it was at that time maybe a disruptor, but it became a kind of evolution. This is the barber surgeon, which we get here and there references in the medieval period. It was more of a show. It would be a surgeon who would actually be a barber, go perform some surgery here and there. But Al-Zawari has been documented as a father of operative surgery right from some about 936 to about 10,013 AD. While all this surgery and all these things were going on, there were three things which required absolute disruption. And the first, we needed to manage the pain that we were giving to the patient when we were operating. We needed to control the infection that resulted from our surgeries. And of course, we wanted to improve the surgery. So we give credit to Dr. T.D. Morton, who actually thought about ether, and that's the picture from an ether dome in Massachusetts, where the first time somebody gave ether to a patient, thankfully, and did the surgery so that the patient did not feel the pain. And then what this disruption became an evolution, we know the anesthesia that we are evident today. And then came Joseph Lister. He talked us about antisepsis. So the big surgeons who would walk in with their shoes, with their dress, and they had the cleanest environment, learned to wash hands and learned to use antisepsis. So these were the two disrupting things that happened, but actually became evolution, became and made surgery safer for us today. And we cannot think of doing a surgery without these two. We cannot move into a theater unless the patient has anesthesia and we have taken care of all the abscess. And then, bigger the surgeon, bigger the scar. So that was the ego of the surgeon who would do the biggest scar surgery and say, that's the surgery to do. But were we improving the quality of the patient? The biggest disruptor there came, laparoscopy. We had to make several personal compromises. We gave our 3D vision, we did counterintuitive movements, we dealt with tremors, we depended on our assistants, we got a bad vision, but we said, yes, this disruptor is making me do something which is in benefit of the patient. I'm not very sure at that point of time we really felt that as surgeon we were really benefiting. We were, but I think we did it for the patients. But as Dr. Arnie also showed, this was how the laparoscopy started. People used to peep through one hole, maybe have a teaching aid, but they were getting nowhere. So this disruption in the vision technology came with actually addition of video. And I would give credit to Dr. Karma Nazat, who actually introduced the video technology to the laparoscope head. I don't think anybody in the audience can think of doing a laparoscopic surgery without a video. But what was it a panacea? It wasn't, because we realized that 2D vision on a 2D screen was not really everything. We needed the 3D vision, which we naturally have. And there came so many modifications of 3D. We had a 3D laparoscopy. We are talking about 3D in our robotic systems, open console, immersive 3D, and so many discussions. But it is a disruptive thought. It is a thought that has gone into the surgeon's mind that do not do a 3D surgery on a 2D screen. You need to have a 3D vision. So that translated into an immersive vision or an open console. The debate is off, and I think we can all debate for hours together as to which is better and which is not. But where from this, the other disruptor that actually made us think is the straight stick. We were doing our surgery very well with our open hands, and then we were made to do straight stick. So we needed something better. So when Ford was asked to make a faster horse, he said, why not an automobile? And that's the concept of where physics met biology. I thought I left my physics when I joined my medical school, but today I'm everywhere with physics. We have the same fulcrum, we have the same pulley, we have the same system to do the operative work that we are now using it to use like our wrist. I think it's again a game changer. It is a disruption, but this disruption has led to so many evolution. So this is now then changed into this kind of devices, which all of you are using, so many technology. Again, two people, one, Dr. Fred Moll. I think his dedication in the beginning with the intuitive surgical really refined these things. And of course, the slide cannot go without Arnie, where I think from 2001, he helped them refine it so much that we get the best instruments, and that got translated into our little masters, which we just move and it's like magic. So I don't think this is a disruptor at all. It is actually an evolution which we were waiting for years together. And that's what has happened. So this disruptive technology which we thought is an evolution in the sense because we could not imagine, and I could not imagine a decade back, that I would be performing my surgeries with such instruments which gave me such great maneuverability. And of course, these are the logical advancements. I need not go. We understand all this. So where are we now today? We have moved from freehand surgery to minimally invasive conventional laparoscopy to robotic surgery. But what's there in future? Do we have something more? This is the OR, which we all know. We know this OR is now, looks a little futuristic, But it's there everywhere, so it's not really a futuristic. Do we know how our future OR will look? It's kind of something where a lot of technology will get through. And I'm sure as we thought a decade back, oh, this robotic, it will come and go. But it didn't. And that's what the gut feeling here somewhere kicks in. I had this gut feeling 10 or 12 years back when I was exposed to robotic, and I think Dr. Som had the same thing. We were really struggling together with different specialties as to how to use this technology and this machine. But I think all of these will get integrated in our OR very, very soon. We are in the telepresence, but will we be getting into this telerobotic, a distant surgery? It's the thought people are trying to do, but I'm sure in another 1 decade, we will find that this is not really unachievable. So what would we look at? Are we reaching there? I wish we could. COVID would have really helped us when we were sitting at home, like thinking, when are we going to go back to our elective surgery? Or will we reach, hey Siri, perform my hysterectomy and I go to sleep? Will that happen? But that's happening. Some robots are now independently performing some steps of your surgery. So that's the automation that is coming in. Again, we should not close our eyes thinking, oh, it doesn't concern me. I don't need to know about it. You need to know about it. Because these technological innovations, there are some of them already there. For example, the 3D printing. And this is something which I'm using. So it's not that something in future. So you can use this technology even before you have taken your patient in the OR. This 3D technology with the VR can actually help you perform your surgery for a junior surgeon. Do it before you enter the theater, you'll get more confident. But what if I can get this technology on my console? Can this 3D model superimpose on my surgery while I'm performing the surgery? Can I have this augmented reality and artificial intelligence on my surgery? That is something which I would look at. Look at this stage 4 endometriosis. Can this preoperative 3D modeling or VR give me an idea where my lesions are? Have I cleared the whole thing properly? This is what we are looking at. This is again a VR application of in an endometriosis surgery. This acknowledgement from Ottawa University, which we are working with Dr. Sukhbir Singh, where you can see now there is a endometriotic big module, that's the red one, which is being depicted in a VR. We can see it in the VR environment in a 3D, and do a kind of virtual surgery before you have actually gone in. You have vital structures all around it. So this is something which, again, is not too much far away. We will all have the access to these technologies. We already have access to this technology. You can put your ultrasound probe with the robotics, check where your fibroids are, see if the cyst that you are seeing is an endometriosis or is there a solid lesion inside it. This is something which we have done in our own OT here. So these technologies are, although we are not aware, it's not accessible to everybody, but it's there with us. Are we going to use it? Google Glass. Now what I'm talking about, having the image with your surgery. The Google Glass, I think all of you know, there is a small part of your glass that will give you some other image. Imagine as a surgeon, you wear the Google Glass and you're getting into a multiple myomectomy. You have the MRI picture running in the corner. I think most of you will think it's disruptive. It will disrupt me from doing a surgery. But remember, when you drive a car, your rear view mirror is always there. You just go into look at the mirror when you want to check, but the rest of the time you're focusing on the street, right? So this is how a Google Glass can help you have the images running on the side of your screen, but you're still performing the surgery with the full focus. Now, that's the car I drive. That's the augmented and artificial reality I get. So this car has the safety mechanism that if it comes through, now supposing this car that it saw a pedestrian and stopped, supposing my augmented reality in the robotic platform tells me, that's the ureter, stop, 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 and it stops. It doesn't let me cut. Wouldn't you like it? It will definitely make your surgery safer. So this kind of intraoperative insight, this is again acknowledgement from Alex Motry and his group, where they have superimposed by taking multiple surgery recordings and created something where you can do it. They have also done some uterine models, which I can show, where the images that have been created get superimposed on your surgical screen, and then you can actually work better. So with the robot that we are already here, we can use all these things. And I think Intuitive has a Iris the hub, which can give you so many things. But this is all just the technology to do your surgery. What are we getting out of it? Are we learning? or are we just playing with gadgets? We need to have these kinds of implementation of VR, AR training exercises. It democratizes access to learning. So it's not for somebody who has an access only can learn. You can learn anywhere, because to learn surgical skill, you'll need a lot of hands-on training. You can actually get lack of exposure because you actually in your training did not see certain cases, but you have access to their recordings and simulations, and you can learn. These things will help you have self-assessment. You can assess, you can watch your surgeries, learn it. You can self-audit and see what I'm getting wrong, how can I improve. And of course, use it to teach. So these data application is just like as Arnie also mentioned, is like sports person. You watch yourself and make corrections. So this kind of capture, and this is thanks to surgical sciences, which help me get these, an intuitive, which helped me get these little slides to help, where you can actually learn from your own kinetics as to how you are moving these instruments. Now, when you move that, you know how an expert is moving and how you are moving, how you can better it. So these are the technologies which can make you better surgeon. Arnie mentioned about my app. Now this app we are all using it here in India as well. So this app can, at the end of my surgery, just not tells me what I'm doing, but can give me a complete evaluation of which instruments I use. The biggest information I take from this is how many minutes I did not use my instruments. What was I doing in that time? Was I going to the bedside to get something done, or was my bedside was slow in getting my instruments exchanged? How many times I exchanged? What did I do? Making me more and more efficient. So these are all the things that you can learn. Again, with simulation. This is something which, thank you, Mr. Anders, who helped me from the surgical sciences. The simulation systems are available here. You can go and practice and see. Given the education curriculum, a surgeon would rather be the first passenger of a pilot than a pilot being the first patient of a surgeon. Do you agree or not? At the time when a surgeon comes out from training. So role of simulator can actually help you overcome that. Thus, we know that the number of intraoperative errors by somebody who has learnt on VR trained simulators is far less than somebody who has a standard training. So this AR and VR delivering advanced surgical training for medical students, which is something as an association we must look forward and help. Learning the surgery, the art of surgery. Surgery is not mathematics. It's not always the same. 2 + 2 is never 4. So we had the system of Guru Shishya. We know in India, a guru or a teacher will teach and he can teach few. What would we do? We can even do remote learning. We have not mythological, but our old story of Eklavya, who learned from remote. He was watching archery was being taught from a remote area and learned. So we can use that in our system also. Now, remote learning or in OT learning can happen with dual console. This is me and Anupma operating at her hospital. But all of us are not fortunate enough to have dual consoles in our teaching places. What could we do? We can give them the same experience by connecting this to the VR headset. So instead of watching my surgery, which I'm doing in 2D, 3D, watching them in 2D and trying to learn, they can wear the headset and learn in 3D. We can also teach them recorded surgeries later. This is a small triest I had with a VR, trying to teach a VR surgery, and this presentation we made at SRS Melbourne. But these are just baby steps. These are all things that can happen, and I believe are absolutely reality. Now, VR surgery. Surgery is happening somewhere else. This is a complex surgery. How can I, sitting by a surgeon operating in New York, if Arnie is operating, how can I sit in Hyderabad and learn the same surgery? We can get connected through Google Glass. We can get connected with VR headsets. And then while he's operating, I can be one of the avatars with him and actually maybe give him suggestions or do something. So these technologies they look like disruptors because we are really used to doing our surgery in a certain way. But I believe that something like this really has no place today. So it's not that it's money for nothing, but we need a positivity of whatever it is, the newer technologies. I think when Arnie wrote this editorial, he talked about robotics, but I will extrapolate it to all the new technologies today, that the glass is not half empty. It's always half full. So we need to understand that, I spoke yesterday in the inauguration as well, whatever technology is coming, we as surgeons have to understand how best to use it for our clinical practice. So responsible deployment of that technology. Healthcare is evolving in every field technologically, and so should be our operating rooms. Patient deserves safe and effective care. We must not forget that. And every surgeon deserves access to proper instruments, expertise, and insights. Thank you very much. I hope I have created some disruptions here. Thank you so much. And thank you for my team for always being there in my crazy ideas. Thank you.